All right, we're live, I think. Yep. So I'll just send you the link afterwards then.
Okay.
Okay, can you see that everything?
Yes.
Okay. Just start a timer too. Okay. So I'm Becca Russell, and my sponsor for this project was Dr. Natasha Alligood. My mentor is Patty Kaiser, and my faculty advisor is Dr. Diana Jollis. And my project title is Using Exercise for Effective Care of Pregnant Women with Obesity and Depression. Here's a picture of some of the past and present midwives in our practice. So depression and obesity during pregnancy are major problems, costing prenatal and postnatal care more money and using more resources. The obesity rate in women in childbearing age is 31.8%. This high obesity rate is causing intergenerational cycles of increasing obesity and diabetes. High depression and suicide rates are also a major problem, with depression rates being 12% in the second and third trimester and 19% postpartum. At UPMC Susquehanna, OBGYN, during a chart review, it was found that there was a low screening for depression during pregnancy at 35%. There were no patients exercising during the baseline data collection. Lycoming County in particular has a high obesity rate at 40.9% in women in 2011. For available knowledge, regular physical activity has many benefits in pregnancy, including weight management, reduction in the risk of GDM, increased recovery time from delivery, and depression management. One study in particular showed that moderate aquatic exercise lowers the risk for postpartum depression. Screening for depression should be attained at least once during pregnancy. Exercise apps can increase self-monitoring and adherence. My rationale of Right Care model was used for effective care, and Right Care is defined as putting patients' health first while providing effective and affordable care. The interventions used for obesity were diet recall, nutrition, discussion, water intake, and exercise. The interventions used for depression were referral to counseling, sleep, nutritious diet, and exercise. And these interventions were used to calculate the Right Care score. The depression screening and exercise rationale came from ACOG's perinatal depression screening and their exercise recommendations. The aim of this project was to increase exercise in obese and depressed pregnant patients by 50% in 90 days. This was measured by evaluating the number of patients exercising through the exercise app being taught during non-stress tests and the patients exercising in the case management log. This project was done in a rural hospital in Williamsport, Pennsylvania, in both the OBGYN clinic and labor and delivery. There are 6 physicians and 8 midwives working together with a collaborative relationship. Approximately 100 women give birth each month there. The sample was a convenient sample of the patients seen in L&D and in the office. This is a predominantly white community with all types of insurances. This project was completed over 8 weeks with 4 planned due study act cycles of 2 weeks each. Each cycle consisted of a different intervention. The planned interventions for PDSA1 were screening all of my patients seen in the office with a PHQ-2, PHQ-9, and BMI. If they screened positive using the PHQ-2, then the PHQ-9 was used. For patient engagement, I taught obese pregnant patients how to use an exercise app during their non-stress tests and to report exercise each appointment. All of the patients that screened positive for obesity or depression in the office were placed into the case management log. These patients were taught the interventions previously discussed, including exercise. They were called weekly to review their successes of the week. Team engagement was planned as a weekly team huddle for the first cycle. This was changed into an exercise competition after PDSA1 and tracked weekly. The study of the intervention data was collected weekly and placed into aggregate data forms and run charts. The run charts were analyzed for shifts and trends. These represented a change in the process that was significant and were helpful to change the intervention each cycle. This slide represents the process and outcome measures used for each intervention. There were 10 total measures for this project. The aim is the first measure and was previously discussed. The process measure for screening was the percent of patients screened, while the outcome measure was the percent of patients with a plan in place. For the patient engagement, the process measure was the percent of patients the tool was taught, and the outcome was the average number of exercise encounters per week. In the case management log, the percent of logbook entries were the process measure, and the mean scores of intervention, the right care scores, as the outcome measure. The team exercise competition, the percent of team members joined, was a process measure, and the average number of exercise encounters per week was the outcome measure. The balancing measure was the average minutes of wait time while teaching the exercise app during non-stress tests. Quantitative data was analyzed with run charts and aggregate data. Qualitative data was collected and reviewed in the Do Notes. This project was excused from review by the IRB at Frontier Nursing University. There was no outside funding received for this project. For my results, screening for depression was increased from 35% to a median of 90% for BMI and depression. There was 99% of patients who had a plan in place. 100% of patients eligible were taught the exercise app. There was an average of 1.12 exercise encounters per week of the patients taught the exercise app in labor and delivery. Of those patients, the average BMI was 40.2. 47.6 of patients that were taught the app exercised at least one time. In the case management log, 95.8% of eligible patients were followed with scores averaging 80% for the 8 weeks, with 16 patients being managed. The team exercise competition had 82% participation, with an average weekly exercise encounter of 3.34. Overall, the aim was to increase exercise, which was increased by 43%, not quite meeting the goal of 50%. The balancing measure had a median of 2 minutes of wait time, which was less than the goal. In PDSA 3, it was identified that a referral to counseling needed to be reviewed, and there were 2 patients that a referral was placed to mental health for which could not be done, as there is a restriction for APRNs with referrals. These patients were given a referral by their primary care provider and were being followed in the case management log. In PDSA 4, the goal was to work around the broken APRN referral by having patients schedule through self-referral counseling. Also, an attempt was made to fix the mental health referral problems with APRNs, and messages were left with multiple power figures, including the PA Department of Insurance. This is an ongoing issue that will need follow-up, as these patients deserve to have the care they need. This run chart is for my AIM, and it's for the patients exercising to improve obesity and depression. So this is the aim of the project, which combined patient engagement with a case management log to evaluate the percentage of patients who were exercising weekly. Overall, exercise was increased throughout the project by increasing the exercise on patients doing non-stress tests, as well as the patients who were being managed for obesity or depression in the case management log. This run chart shows the percentage of patients who were screened for BMI and depression. Screening was increased until new providers were added. When the new providers were added, sometimes they didn't always screen 100% of the time, so reminders for providers were put into place to increase the screening. This table represents the data from screening for the 4 cycles. There was 200 patients screened with 7 positive obesity screens and 9 positive depression screens. The average BMI was 28. Average PHQ-2 was 0.81, and average PHQ-9 was 11.81. This is a patient engagement run chart, and engaging patients during their non-stress tests to increase exercise during pregnancy was done through teaching an exercise app, motivational messaging, and giving specific goals. These patients were tracked over the 8 weeks to increase exercise from a baseline of 0 encounters per week to a median of 1 encounter per week. As you can see from the interventions attempted, it was difficult to get patients to increase exercise. There are many reasons patients used as an excuse not to exercise, including they were too tired, lazy, or they just did not want to. This is the run chart for the case management, which is the right care scores. And the case management log was implemented for patients with class 3 obesity or moderate depression. And the patients were managed weekly with 3 interventions plus exercise. The average weekly score of all patients was calculated and shown in percentages for the right care score. This table shows all the right care scores for each intervention for each cycle. There were 7 patients managed for obesity and 9 managed for depression. In the last 2 rows are the exercise and total right care scores over each cycle and in total. Exercise had an average of 51%, while the total average right care score was 80%. Adherence to the interventions toward the right care scores were more accomplished in the obese group than the depressed group of patients. The biggest success of this project was that exercise was increased in obese and depressed pregnant patients by 43% over the 8-week period. Universal screening for depression and obesity increased from 67% to 93%. Also, 10 out of 21, or 48% of the patients engaged with the app exercised with a total of 66 exercise encounters over the project. The Right Care score of the case management log was 80% for the 8-week period, with exercise being an intervention for each patient. Screening interpretation, managing obesity and depression during pregnancy can be accomplished by teaching patients different interventions while engaging them into self-care. Exercise is a simple tool that can improve conditions during pregnancy, whether done with an app or on their own. Increasing exercise can impact the community to decrease healthcare costs as well as the patient in their long-term life. Using a standardized tool increases detection of positive screens for perinatal depression. Obesity and depression are a worldwide problem and an important part of pregnancy that need to be conversed with patients more frequently to improve lifestyle and community health. The referral system for mental health is broken and more needs to be done to be fixed. Also, encouraging the team to discuss exercise with their patients can improve patient adherence. Progress in this project was impacted by the inability of APRNs to place mental health referrals. The broken system has an impact on the providers in the office, the patients, as well as the community, as there is an important role missing linking patients to the care needed. There was also a small sample of positive screens for depression. This was a convenient sample from a small practice and may not be generalizable to a bigger city or practice. So in conclusion, exercise was increased in pregnant, obese, and depressed pregnant patients through teaching an app and interventions in the case management log by 43%. Mental health care and referrals needs continued work for a more permanent solution. Screening for obesity and depression is important to reduce costs and enhance quality of life. Teaching an exercise app and case management log is not sustainable as it is very time consuming. Here are my references and my discussion questions.
That was a good job.
Thanks.
So in disclosure, I just got my feedback just a few minutes ago.
Oh, okay.
So when I do mine, there'll be a lot of changes to happen, so it's in the works. But
I don't even see my feedback yet, so I didn't look at it yet.
Okay. So of course you did a great job, and it's hard to evaluate, not be able to see how you're going to be that day standing at your location, but everything read really well.
I have to practice it a lot more, so I'm not quite just reading it, but
I've got this whole weekend and Memorial Day set aside to just, that's all I'm doing. So I'll be more polished then for sure. So I'm not sure about the lines, like on the analysis and conclusion slides, there might be too many lines of information. I think they like 7 to 8 lines, but that's just something, and then it would like just overflow by one word a couple of times. So that's just something I had to look at with mine because I'd gone too much on the lines. You had really good, the contextual elements that you put at the bottom of that chart, you know, that call out to your contextual.
Yeah.
That was really good. That was something that just added to that and just punctuated what you were saying there. And it gave new information without having to use a whole new slide. On the discussion slide, you gave out some great numbers, some good data. So I don't know if you want to use more, throw a few numbers in there with your words.
Okay.
Just kind of, because I mean, it was great information. So just for the lay person that's in your audience might like to see that. But other than that, I think everything looked great and sounded great. And I like the project.
Good. Thank you. Which slides did you say were too many points? Do you remember?
I think I jotted down analysis and conclusion.
Okay. I'll have to look at that.
So, and it may be just fine, but other than that, I mean,
I'm sure I can take some words out somewhere. Good.
I had to redo a lot of mine because I was just, sharing a lot of information. So awesome. Good job.
I appreciate the feedback. I'm super nervous. So I have to practice 8,000 more times, but
right. And that day of, I'll make sure I don't have too much caffeine or anything like that to keep me because I will respond to that if I don't
Yeah.
watch it.
And I have to talk slow because I'm a fast talker and I have to try to talk slow.
I am too. So it's like first thing of mine. Did you time yourself?
Yeah, it was only 12 minutes, so I could talk slower.
Well, then you'll have your discussion,
Yeah.
which it's hard to evaluate that here. So.
Do you want me to time you or do you have a timer there?
I just got it ready to go.
Okay.
So I'm gonna get a swig of water. I got
Okay.
it right now. And our topics are very similar. So all right, can you see it?
Yep.
Okay, good. Okay. My name is Jennifer Carter. I'm a women's health certified nurse practitioner. I have a sponsor mentor both, that is Dr. Melissa Zapata. My faculty advisor is Dr. Diana Jollis. The title of my project was Improving Patient-Centered Obesity Care in a Women's Health Private Practice Utilizing a Shared Decision-Making Tool. There's just a quick snapshot from inside the practice where we would have a Fun Fact Friday. And on this day, we put a BMI chart by the scale for the patients to look at while they're being weighed, and then just a cute little photo to go with that. So the introduction, the United States has an obesity rate of 39.8%. And patients who are obese have increased risks of hypertension, dyslipidemia, diabetes, coronary artery disease, strokes, and certain cancers. The economic burden in our United States is $149.4 billion. Some of that is accountable by taking note of premature disability, mortality, decreased productivity in the workplace, and absenteeism. The local problem here in Hunt County, Texas, the obesity rate is 32%. A chart audit done prior to the project revealed that 62% of those patients in that audit were either overweight or obese, according to their BMI value. Also, the provider, Dr. Zapata, had recognized that obesity was an issue in her practice, and she was dealing with related issues of abnormal uterine bleeding, infertility, irregular cycles, and those such issues. Also, in this practice, there was no shared decision-making tool to facilitate obesity care with patients. Available knowledge. Shared decision-making is an important concept with obesity care. We want to simplify the patient's contribution. Team members need to have some education, and we need to utilize patient-focused tactics, and then give them some self-management interventions to lead with. Some things that influence the patient are their own education level, their knowledge, and beliefs about their own role in their care. The rationale, patient engagement was utilized using that pre-visit questionnaire that we developed, the shared decision-making tool, and the Ottawa Shared Decision Guide. The team was engaged using debriefs. We debriefed by plan twice weekly, and we had a survey that had 5 Likert-style survey questions to moderate how the project was going and what their vision of the shared workload was. And we also incorporated some multi-tiered learning, which included some read and sign activities, Fun Fact Friday, and some other activities that we'll go over. The aim of this project was to increase patient-centered management of obesity care in a private women's healthcare practice to 80% over 90 days. In methods, we are at Zapata Women's Health Center. We are a private practice in suburban Northeast Texas. Staff consists of 8 people, 1 doctor, 1 nurse practitioner, myself, 2 medical assistants, 3 office staff, and 1 office manager. Our patients vary in socioeconomic and ethnic backgrounds, and the payer types are self-pay, private insurance, Medicaid, and Medicare. Interventions. A rapid cycle quality improvement model was used for this project. There were 4 Plan, Do, Study, Act, or PDSA cycles utilized. There were 4 core interventions. There was the team engagement intervention with debriefs, Patient engagement was done by a pre-visit questionnaire and the shared decision tool. And then patient satisfaction was evaluated using a post-visit survey with 5 Likert-style survey questions. To study the intervention, statistics and feedback were collected twice weekly. Interventions were adapted and improved where needed. The data that was collected was put into an Excel file. Then it was calculated and put into run charts. Those run charts were utilized to track the effective and continuous system changes for measurement of improvement over the time of the project. This is our measures chart. It shows the different elements that we use for teamwork, patient engagement, and the satisfaction. In the operational definition of the teamwork, we have the team members attending the debrief out of the total number of team members. And then the score of the post-debrief survey of the work equity question was our outcome. Patients were engaged by completing the personal decision guide, and we counted those out of how many patients should have completed those guides. And then there was a score of options 1 through 3 on that guide, and we went with the highest possible score of those decisions. The process for the pre-visit questionnaire, we had visit questionnaires given to the proper number of patients that included patients that had been away for 6 months to a year and patients that were new to practice. And then the mean of that was the score of the obesity reference question. There was one specific question that asked if the patient realized they needed intervention for obesity or overweight. And then with patient satisfaction, we had the number of surveys completed over the number of patients, and then the scores of those surveys. The balancing measure of this project was increased workload on the staff members due to the project. An analysis of mixed method quantitative and qualitative data were collected. The quantitative used a Likert number score averages, and the qualitative used the surveys and the scores. Run charts interpreted by common special cause variations. We were excused in this project from the FNU IRB review board, and there were no outside fundings for this project. The results of the measurements, when we had no baseline for these tools or interventions, we had the goals column shows you there what we had for the team implementation, the patient engagement, and the patient satisfaction. And we can see in the results column our aim to increase obesity care to 80% in 90 days did fall short of the goal, but increased by 69% with a baseline of 0. This is the scale of the team engagement survey. You can see that the kickoff was postponed. We had some low staffing situations. We had maternity leave. We had family emergencies, and so we had to postpone. And then we picked up right there, and then there was one day that I was out, so we didn't have a debrief on the day we had planned. But then we had full staff that gave us equal, in 4 debriefs, we had good attendance. And then we had a very high patient volume at one time. You can see the dip in attendance there. And then it came back up. So in those debriefs, we had the workload survey question. And this reflects the scores of those questions. Do you feel like the workload equity is fair? And the pre-visit questionnaire, we wanted to gather that proper population. And so we're looking at how many were completed by the ones that needed to complete it, because that's what we need to go from there. And we can see that on busy days with more OB visits, or maybe staff was low, that's when the numbers were lower. The highest value came on a day that we were very busy in the office and the patients were in the waiting room longer, where we were giving them the forms. They actually took that time to fill it out more often on that day. And at one point we were having trouble collecting the tools, so we copied them on colored paper, and that made it much easier for the staff to collect those tools for us. And this is the patient plan choice on the Ottawa Shared Decision tool. There was a choice of a plan developed with the provider and the patient. There was a choice to do the plan on their own totally, and there was a place to choose internet or app. And we can see when there was more time with the nurse practitioner, they actually chose the plan that would involve the provider. And on the patient experience survey, our scores are related there. And we can see also, again, when the patient volume is high, time with the practitioner is low, the scores were not as good. Patient-centered obesity care increased to 69%. Team engagement grew from 38 to 100% twice during those cycles. And patient engagement scores increased from 50 to 66%. The pre-visit questionnaire completion started low at 28% and increased to 82%. And then the post-visit survey scores went from 84 to 92%. Strengths of this project ended up being the fact that we were addressing obesity care, and we started in January. That is when health and obesity and weight loss are front of patients' minds. And so it happened to be a subject and topic that was coming up anyway. And so really the timing was one good strength of this project, and the buy-in of the team. Teamwork was influenced by patient-centered care. The outcomes were consistent with evidence-based correlations of increased time with the patient. There are surveys and many research projects out there that show that when patients have more time with the provider during their visit, the outcomes are consistently better. And impact on systems, we had improved teamwork and team engagement as time went along. We even had one of our team members who was very proactive, wanted to lead a debrief. She was very active in getting our Fun Fact Friday information together and really led the team on. And then embracing patient engagement in the practice. Some limitations: the tools were modified specifically for obesity care. They weren't evaluated for reliability with other health issues. And follow-up was limited. The time frame of the project was great for getting things started, but we need to now follow up and have return visits, et cetera. And this may not be generalized to a larger practice or that had multiple providers, or maybe a practice that has more than one location like this practice. In conclusion, patient-centered care is attainable through the use of the tools that we use in this project. Tools are sustainable with strategic modifications for other people groups, other populations, other health issues. Evidence-based practice was utilized, and this project can be disseminated to other practices, women's healthcare practices, or even family practice with a few modifications. These are the references, and these are the discussion questions that are planned.
That's really good. Your slides look good. I like your charts.
Oh.
The only thing that, like, maybe you just have to practice talking about one of the first 2 run charts that I remember you like stumbled over a couple words, but just practice that a couple times. Everything else sounded really good. Your tone was good. I like the part about the strengths that you started in January. That's really true. That's cool.
Yeah, that worked out nice.
Yeah.
I do have a lot of revisions to do and a lot of practice to do.
Yeah,
but this is good just to kind of go over it.
Mm-hmm.
You know, actually have to click through the slides and go through that. So
how long did it take you?
Oh, I think it was right at 10 minutes.
Yeah.
9:53, I think, maybe. So, and I'm going to put another picture, the picture of the scale. I'm going to take it out and do a picture of the front of the building.
Okay.
I just decided I'm going to do that instead. I'm going to keep the team picture.
Mm-hmm.
So that's about it. And then whatever revisions that she told me to do. I'm a little bit bummed because I think that she can't facilitate mine.
Oh, no.
Yeah. So that'll be okay. Have you had a chance to watch the other ones that have already gone?
Yeah, I went to the one today and one from last week.
I'm going to try to make as many as I can.
Yeah, it's good to just like watch them just to kind of get an idea of what it'll feel like, I guess.
Right. Are you going to have someone in your audience timing you or giving you a cue on time?
I don't know. Probably not, because I'm probably not going to go over.
Right. And then do you have someone assigned to write down the attendees?
No, I think you said you were able to come to mine.
Yes, I should be. Remind me when yours is.
May 30th at 5.
Oh, yes.
Do you think you can write down the online people for me?
Yes.
And everybody else, I'll just have them sign in when they come in.
Okay. And I had a question about that because it comes up just phone. I mean, it doesn't always have it doesn't have a number.
If they phone in, yeah. I don't know if anybody's going to phone in. I don't know that anybody that I know of is going to phone in. So.
Okay. I'm going to have some phone in. So that concerns me on, I don't know if I could call IT and they could, tell me what numbers it was.
That was their number. I don't even know what the number is. I never really pay attention.
So I've seen it both ways. I've seen it where a phone number comes up, or I've seen it just say phone. Anyway, so if that does happen, then I'll just write down whatever you got. So
yeah. Okay. Thank you.
And that's 5 Eastern time, right?
Yeah.
Okay. All right.
Anything else? I mean, I think we practice.
The next debate is what to wear.
Yeah, well, I'm pregnant, so I gotta see if my jacket even fits, so
Well, congratulations.
thanks.
Is it your first or
What?
your first baby or no?
Yeah,
Congratulations. How far along are you?
25 weeks.
Oh, I love it. Perfect.
I'll probably just won't button it, and it's gonna be okay, I think.
Oh, yeah. Just show that belly.
Yeah.
Well, my husband wants me to wear a red blouse. And I got a new red blouse, and my mom says it's too much power. So
Yeah, I think it'll be okay. I don't know. I'm not an expert on that, though.
I'm not either. I'm used to wearing scrubs all the time.
Yeah.
Anyway, well, you're going to do great.
You
This is
too.
exciting. This is exciting. If you have any questions, you've got my number for text. And
And I'll email this link over to you so you can submit it with the
yeah,
final project.
right. Thank you so much for doing this with
Thank
me.
you. Appreciate it.
All right.
All right, I'll see you later.
Okay. Bye bye.
Bye.